Good morning. In the previous video, we discussed about the definition, epidemiology, etiology, and pathophysiology of the peptic ulcer disease. Now we will go with the further parts of pharmacotherapy of peptic ulcer disease. So, if you see the one more important division is clinical complications. So, if you see the clinical complications, these are the signs and symptoms of the disease. Dyspepsia is one of the major clinical complication of PUD. Because of the dyspepsia or indigestion, bloating, the other features like bloating, abdominal fullness, pain or nausea can be seen. Along with that, there will be water brush. Water brush is nothing but regurgitation of the acid, and along with that there can be the loss of appetite and weight loss. So weight loss cannot be taken as a general feature, because if you see the duodenal ulcer, in some patients of the duodenal ulcers there can be weight gain also, because the duodenal ulcer pain is subsided by taking the food. That's why the duodenal ulcer patients may take more number of food intake, so that there can be the weight gain. So although weight loss is one of the symptoms, it is not true for all cases of duodenal and all cases of ulcer. Along with that, you can see hematemesis. Hematemesis can be seen in the gastric ulcers mainly, and one more feature is melena, which can be seen in case of the duodenal ulcers. These are the very common complications. Along with that, you can have some severe complications of the peptic ulcer. Those are gastrointestinal bleeding, cancer, perforation, as well as penetration. So if there are these complications are present in PUD, that is called as complicated PUD. If there are no these these severe complications are absent and you are having only the above symptoms, then it can be called as uncomplicated PUD. So this is the main difference between the complicated as well as uncomplicated PUD. Next, coming to the diagnosis. So if you see the diagnosis, now we have invasive as well as non-invasive methods of diagnosis are there. Invasive method, the one of the very important diagnostic diagnostic tool for this PUD is endoscopy. But endoscopy is, although it is a very precise method for PUD determination, it is not recommended always. It is very sensitive, specific and safe, but the only drawback is it is expensive, and it will be somewhat uncomfortable as it is a invasive procedure. And routine endoscopy in patients presenting with dyspepsia without alarm features is not necessary. So the endoscopy should be done only in the patients with the alarm features. The alarm features which indicates the endoscopy are dysphagia, that is difficulty in swallowing, pain on swallowing, unintentional weight loss, gastrointestinal bleeding or anemia, and persistent vomiting, and if the patient is on NSAIDs therapy or warfarin. So if the patient is having any of these conditions, in such cases the endoscopy is recommended. Otherwise there will be no need of endoscopy. Generally, if endoscopy is not done in such cases, so you have to check for the pre-endoscopic scores in order to proceed for the treatment. And along with the endoscopy, so if there are complications or alarm features are there, in most of the cases the endoscopy should be combined with gastric biopsy. So in order to rule out the gastric carcinoma, you by gastric biopsy will be done. The gastric, after that histopathological investigation is done for that biopsy. Next, non-invasive methods. Non-invasive methods, the important non-invasive methods are only useful for H. pylori associated peptic ulcer disease. Most of these non-invasive methods are useful for determination of H. pylori infection. So the first very popular one is the urea breath test. This urea breath test is depending on the ability of the H. pylori to split the H. pylori is having an enzyme called as urease, which is also responsible for the mucosal damage. So this urease, it can convert the urea into carbon dioxide as well as ammonia. So the principle of the test is this only. If you are giving the urea which is labeled, so generally C13 labeled urea will be administered in the patient, and if the H. pylori is present in his gut, it will cause splitting of that the splitting of that urea, that is carbon 13 labeled urea, into CO2 as well as the ammonia, and whatever the CO2, that is the labeled CO2, C13 labeled CO2 will be exhaled, which can be detected. So the detection of that C13 labeled CO2 itself indicates the presence of H. pylori, because if H. pylori presence, then only there will be that action of the urease, that is the splitting of urea into carbon dioxide as well as ammonia. That carbon dioxide is only exhaled, which is detected. This is also very sensitive as well as a specific test, and it is more than 90% accurate, and it is useful for both initial diagnosis of H. pylori infestation as well as for confirmation of the eradication of the H. pylori after anti-H. pylori drug treatment. But the only drawback is the performance of this test in young children is debated. So how safe it is in young children, that is a question mark. And along with the urea blood test, serological tests are there. So H. pylori in the if H. pylori is infesting the GAT, definitely the antibodies, H. pylori antibodies will be developed in the body, which can be assessed by ELISA test or Western blot test. So this is one more method, and it is also precise method. One more thing is stool antigen test. So if you see these two also, these tests are also sensitive as well as specific, over 90%, and used for the initial diagnosis as well as confirmation of eradication, both serological test as well as stool antigen test. And one more method is radiological testing, which is very common, and generally barium meal is used for this test, but it is not accurate, it is not much accurate and less sensitive. So you won't have complete idea about the PUD because of the radiological diagnosis. So the precise test or the preferable test is endoscopy, and those patients with low risk, there is no need of endoscopy. Endoscopy can be done only in the patients with the alarm features. And those people who are not undergoing the endoscopy, in them you can go with the pre-endoscopic scoring. So if you see, there will be pre-endoscopic scoring as well as the post-endoscopic scoring systems are available, and they are used by the physicians. There are some 10 types of scoring systems for the PUD, for the diagnosis of the PUD, depending on which the physician can proceed to the treatment. So if you see the pre-endoscopic test, it includes GBS, that is the Glasgow Blatchford score, as well as abbreviated Rockall score system. The main objective of this is to avoid the endoscopy and hospitalization in the low risk patients. The parameters of the scoring in the Glasgow Blatchford score system includes hemoglobin, melena, heart rate, blood pressure, syncope. So these are the parameters to which the score will be given, and afterwards the total score is seen. If the score is high, means there can be recommendation to go with the endoscopy. If the score is less, accordingly the treatment will be planned. And abbreviated Rockall system, the parameters taken are age, shock and comorbid conditions. And if you see the post endoscopic scoring system, the post endoscopic scoring system is used to manage the peptic ulcer disease, as well as the other complications, that is lethal outcome. All these will be assessed. So if you see, there are three very popular post endoscopic scoring systems, that is Glasgow Blatchford score, Rockall score system. These are common for both pre endoscopic as well as the post endoscopic scoring systems. And one more thing is the Baylor bleeding score. It is also very popular scoring system which is useful to know about the bleeding tendency of the GAT in the PUD patients. So the main objective of this Baylor bleeding score is prediction of lethal outcome, rebleeding, needs for blood transfusion, and there is in order to assess if there is any need of surgical intervention. And if you see the other two, that is the glass GBS as well as RS, they are having the same objectives, as we, that is the main objective of these scoring systems is to manage the therapy of the PUD. Next one is to manage the PUD. Parameters of the scoring includes in the these parameters are only for Baylor's bleeding score: age, number of parallel illness, severity of the illness, site of bleeding, stigmate of the bleeding. So next, coming to the before entering into the management of peptic ulcer disease, the management includes both pharmacological as well as the non-pharmacological methods. But here, before entering into the management or treatment of the peptic ulcer, you have to check the physiology of the gastric acid secretion, because the normal gastric acid secretion is interfered because of the pharmacological intervention or pharmacological agents. So if you see the gross anatomy of the stomach, which is responsible for the production of the acid, it is having mainly the immediate part of the after the esophagus is called as the cardia, which is the first part of the stomach, followed by the fundus. Next one is the body. So this is the body, and next one is pylorus. All this is pylorus. So if you see this, so this is the pylorus, and if you see, different gastric glands are distributed throughout the stomach. So you can have the cardiac glands in the cardiac region, and fundic region is having 5% of gastric glands are present. And if you see the cardiac region is having 5% of the gastric glands, and 75% of the gastric glands are present in the fundic as well as the carpofundic region. And if you see the pylorus, in the pylorus, the broad funnel type of structure in the pylorus, it is called as a pyloric anthem, and the canal shaped thing is called as a pylorus canal. So this anthem consists of so many glands, but these glands are mainly mucus glands as well as enteroendocrine glands. So that means different types of glands are present. That is, you can have the mucus secreting glands, you can have the enteroendocrine glands, you can have gastric glands, which are gastric glands are mainly responsible for the acid as well as the pepsin secretion, which are mainly located in the fundic region as well as carpofundic region. So this area as well as this area are the main things. That is 75% of the gastric glands will be distributed in these two areas, and cardiac region also consists of some of the gastric glands. So here one of the gastric gland, you can see gastric gland can be also called as a pyloric gland. So if you see the it is also called as oxyntic gland. The gastric gland can be also called as the oxyntic gland. So if you see the oxyntic gland, it consists of various cells, in which you can have the parietal cell. Parietal cells are the cells. You can have 4 types of cells in the oxyntic glands or gastric glands. That is mucus cells, which are very common, which are responsible for secretion of the mucus. So here you can see the surface mucus cells, and the second type of very important cells are the parietal cells. Parietal cells of the gastric glands are responsible for the secretion of gastric acid as well as intrinsic factor. And you can have some enterochromaffin like cells which can secrete the histamine, and along with that chief cells are present. Chief cells are the cells which are responsible for secretion of the pepsinogen, and there are some enteroendocrine cells are also present, so which can secrete somatostatin. So these are various cells which are present in a gastric gland or auxiliary gland. If you see the pylori gland is not having any parietal cell, or it is not having any chief cells. It is mainly composed of enteroendocrine cells as well as mucus cells. So it is mainly responsible for the production of the mucus, as well as you can have two types of enteroendocrine cells, that is the G cells which are responsible for the secretion of the gastrin, and D cells which are responsible for the secretion of somatostatin. So these are various cells present in the pylori gland. So if you see the gastric glands are the glands which are mainly having the parietal as well as the chief cells. These two types of gastric glands, which is composed of these two types of cells, are present in the cardiac region, fundic region, as well as the body region of the stomach. You won't get these glands in the pyloric region. So next, if you see the phases of gastric acid, so these glands present in these areas, they are responsible for secreting the gastric acid, and this gastric acid can be secreted in three different phases. The first phase is it is called as cephalic phase. So cephalic phase is the phase which is because of some stimulation the gastric acid is secreted. It can be the stimulation of sight, that is on seeing the food and tasting the food, as well as on smelling the food. There will be secretion of the gastric acid, which is called as cephalic phase. It is mainly it consists of the neuronal pathways, or it is because of the parasympathetic excitement. And next, coming to the gastric phase. So once the food enters into the stomach, the gastric phase secretion starts. So it is this is because of the local neuron secretory reflexes. So and you will have local nervous system is there present in the stomach, that is, or in the GAT, that is the enteric nervous system. So because of the enteric nervous system stimulation, as well as the vagal reflexes, and it is also involving the endocrine and paracrine pathways. So gastrin as well as the histamine are also responsible for increased secretion of the acid in this particular phase. Next phase is called as intestinal phase. Once the food enters, once the stomach is distended and the food starts entering into the intestine, the intestinal phase starts, and it is mainly responsible for the inhibition of the acid secretion. The above two phases are responsible for stimulation of the acid secretion, but intestinal phase is responsible for decreasing the acid secretion, which involves neuronal as well as the hormonal mechanism. So in these phases, how acid is produced from the parietal cell means, so this is the mechanism how the HCl is synthesized and secreted. So if you see the parietal cell, this is the so here if you see this one, this side is the whatever the apical surface of the parietal cell. On apical surface of the parietal cell, you are having a important pump is present, which is called as proton pump or hydrogen potassium ATPase pump. This particular pump is responsible for it is responsible for efflux of one proton or hydrogen ion, and it is at the same time it is causing the entry of the one potassium ion. So if you see this pump is responsible for this H plus secretion. But how, from where the H plus is coming means, it is because of the action of the carbonic anhydrase. Carbonic anhydrase is one of the enzyme which is present in many of the cells, including the gastric parietal cell. So if you see this carbonic anhydrase, it is having the ability to form the carbonic acid by combining carbon dioxide and H2O. So the carbon dioxide will be diffused into the parietal cell, and H2O also enters through osmosis, where they combine in the presence of the carbonic anhydrous to form the carbonic acid. So this carbonic acid in turn cleaves into H plus as well as HCO3 minus ion. So the formed H plus, it is exchanged with the potassium by this proton pump, and this formed potassium again it will come out through the potassium channels. So that is the another thing. And if you see this so one H plus came, but you want the Cl minus also. So this Cl minus, it is coming from the blood. So if you see this one, this is the blood from where the Cl minus it is exchanged with the bicarbonate. Along with the H plus there is bicarbonate, it is cleaved from the carbonic acid. So this bicarbonate is on the basolateral side. So on basolateral side you are having two pumps, that is one is sodium potassium ATPase pump, which is common for all the cells, and one more pump is bicarbonate chloride antiport. So this is responsible for sending out one bicarbonate ion, and it is responsible for allowing one chloride from the blood into the parietal cells. So this chloride ion, it is coming out, and because of so from here we are having the H plus, and here we are having the Cl minus, so which are responsible for the HCl. So this is the how the gastric acid is secreted from the parietal cell. So it is mainly because of proton pump. The final thing which is responsible for formation of the gastric acid is proton pump. So next, coming to regulation of the acid secretion. So that is the whatever we discussed about how HCl is secreted, how HCl is formed. But when the HCl is formed, that is what are different regulatory mechanisms which are increasing or decreasing the HCl secretion from the parietal cell. So if you see that one, we are having three pathways which are responsible for regulation of the acid secretion. Those are, we can have the neuronal mechanism which is called as neurocrine pathway. So if you see that one, here we have one is neurocrine pathway. The neurocrine pathway involves acetylcholine as the mediator, and we are having the paracrine pathway, which is where the mediator is histamine, and along with that we have endocrine pathway, where the mediator is gastrin. So these are the three important mediators which are responsible for the regulation of the acid secretion from the parietal cell. So first we will go with the neurocrine pathway. So if you see the neurocrine pathway, it is so here you can see ENS. So you are having the enteric nervous system, and the neurocrine pathway involves the secretion of acetylcholine. So here if you see this from the from the ganglionic cells, so here the acetylcholine is released, and this acetylcholine is acting on the from the ganglionic cholinergic nerves. The acetylcholine is released, which in turn acts on the M1 receptors present on the enteric nervous system. So this is in turn responsible for releasing the acetylcholine. The released acetylcholine, it can act by two ways. So one is it is directly binding to the M3 receptors present on the parietal cell apical surface. So on the parietal cell apical surface, we are having muscarinic receptors. The subtype present is M3. So it is acting on that M3 receptors, and it is responsible for stimulating the IP3-DAG pathway. So which causes increased intracellular calcium, which in turn stimulates this proton pump. That is one pathway of acetylcholine action. The another action is acetylcholine. It is acting on, so there are muscarinic receptors present on the ECL cells, enterochromaffin like cells, which are rich in histamine. So the action of the acetylcholine on these ECL cells is responsible for releasing the histamine, so that histamine can start its paracrine pathway of regulation. So the released histamine, it is acting on the H2 receptor present on the apical surface, so which in turn causes the activation of the cyclic TMP pathway. So this cyclic EMP pathway causes which in turn causes increased secretion of the HCl. That is called as paracrine pathway. Histamine pathway is called as a paracrine pathway, and the last pathway is the whatever this endocrine pathway. So if you see the endocrine pathway, it is a gastrin mediated pathway. So here if you see the gastrin, you know that gastrin is present in pyloric region. The gastrin secreting cells, that is G cells, are present in the pyloric region, which are responsible for secreting the gastrin, which is the endocrine hormone. So this gastrin, so whatever the gastrin secreted from the pyloric region, it is acting on the gastrin cholecystokinin receptors present on the ECL cell as well as on the parietal cells. So once gastrin is directly acting on the parietal cell gastrin receptors, it is causing the IP3DAC pathway stimulation like your acetylcholine, which in turn causes the increased acid secretion. The other pathway is the gastrin can also act on the ECL cell, by which it can cause the release of the histamine. So here the important thing is histamine or paracrine pathway is very important pathway, which is responsible for increasing the acid secretion, because histamine can directly release it from the ECL and it can initiate the paracrine pathway. And also if you see the acetylcholine as well as the gastrin, that is the both neurocrine as well as the endocrine pathways, they can act through the ECL cells, that is the receptors are present on ECL cells, so that they are responsible for histamine. That's why paracrine pathway is causing major contribution towards the regulation of the acid secretion. And along with these three types of receptors on the parietal cells, we are having one more receptor, that is EP3 receptor. So if you see these EP3 receptors, these are the receptors for the prostaglandin E. So these prostaglandin E2 as well as the prostaglandin I2. So these receptors, they are the activation of these receptors, it is responsible for inhibiting the cyclic AMP pathway. So these are, so if you see the other three receptors activation leading to activation of proton pump, but the EP3 activation leads to inhibition of the proton pump. So that if you want to stop the acid secretion, we have to block the action of this, or we have to inhibit these receptors, but you have to enhance the EP3 action, or you have to stimulate the EP3 receptors, because the activation of the EP3 receptor is having the negative control over the proton pump, whereas all others, that is M3 receptors, gastrin receptors and H2 receptors, they are having a positive regulation over the proton pump. So this is about the what are the proton pump, how the acid secretion is regulated by all the three pathways as well as prostaglandins. And prostaglandins along with acting on the parietal cells, it can act on the mucous cells. So by acting on the mucous cells, they are responsible for increasing the mucus secretion, mucus as well as the bicarbonate secretion, which is responsible for the protection of the, or it is increasing the mucosal defensive mechanisms. So like this, the acid is the acid secretion is regulated from the parietal cells. If there are more histamine, more gastrin and more acetylcholine, it can increase the gastric acid secretion. If there is decreased incidence of these mediators or those pathways, there will be decreased acid secretion. And if the prostaglandin action is increased, there will be decreased acid secretion along with the increased mucus secretion. So now we have to go with the management of